Let me introduce myself. I'm Marcia Stanton. I'm the Vice President for IHFDA and very happy to be your moderator today. I look forward to the presentation that Dr. Shawn Ryan will be giving to us. And as you can see on your screen, the title of the presentation is Addiction and Evidence-Based Treatment, Including Medication. Let me give you a little information about Dr. Ryan. He originally trained as an emergency physician at the University of Cincinnati and at the same time obtained his MBA while completing his residency. For over 10 years, Dr. Ryan has practiced in the greater Cincinnati area, and for part of that time, he functioned as a hospital administrator for Mercy Health. During that time, he became acutely aware of the issue of heroin and opioid abuse in the region, and since then has been working tirelessly to make a difference in the community. Dr. Ryan serves on many regional, state, and national committees, work groups focused on turning the tide of this epidemic. He's both a board-certified addiction specialist and a board-certified emergency physician. He is also president of the Ohio Society of Addiction Medicine and chair of the Payer Relations for ASAM. Dr. Ryan's very excited to continue his work in the field of addiction medicine and to have the opportunity to substantially impact the field going forward. So with that, I'll introduce Dr. Shawn Ryan. I will tell you, though, that if you have questions during this presentation, you're more than welcome to add them to the right side of your screen. And we will be more than happy to take the questions at the end of the presentation. Dr. Ryan.
Thank you very much. Good afternoon, everyone. Again, I'm Dr. Shawn Ryan, and due to the intro, been explained fairly thoroughly, so I appreciate that. So I'll start with the fact that today we're really going to focus on a few things: the issue broadly, the disease, and then primarily the evidence behind medication-assisted treatment. I will tell you that since I sent this presentation in, new CDC data actually would require me to update this going forward. And unfortunately, we're now seeing every 12 minutes a person die in the United States from an opioid overdose, according to that latest data. So given that backdrop, we'll move forward. I was privileged to announce with the Surgeon General in November of 2016 the U.S. Surgeon General's report on addiction. And one of the most, it was an excellent report. If you have not spent any time on it, please do. In addition to that, it is very, comprehensive, well-written, well-researched, and speaks to a lot of the very important topics related to the opioid epidemic, including things like prevention and healthcare integration, which I'll speak to later. One of the important points that Dr. Murthy made was the fact that we know of at least 21 million people in our country living with substance use disorder. And again, any of the statistics I share today should be taken in a frame of probably a tip of the iceberg, because a lot of this survey data are things that people admit to on these questionnaires. And so we know that there's an immense amount of stigma surrounding mental health and addiction. And so it shouldn't surprise anyone that these numbers are probably significantly underrepresenting the reality. That being said, we have at least an estimated 21 million people in our country living with this substance use disorder, a lot of which have opioid use issues. And it's important for frame of reference to know that this is similar to the number of people with diabetes and 1.5 times the number of people who have all cancers combined. And so when we think that this is just that other thing that nobody really worries about until it hits close to home, reality is it is extraordinarily pervasive, and approximately 1 in 10 people has an issue with substance use disorder at some point in their life. I also very much vehemently agree with Dr. Murthy that we need to do more to address this. It has to change, and that includes substantial increases in funding directed towards the research surrounding treatment and development of treatment resources as well. As mentioned, we're going to talk about this kind of 3-point agenda. The issue in our country, where are we at right now? Substance use disorder, I'm going to describe the disease and how it develops and a few other things, and then we're going to focus pretty intensely on medication-assisted treatment. Substance use disorder is a chronic relapsing disease, and it appears to most public health officials, individuals like myself that work on this issue all the time, that it could potentially be the most expensive one we deal with in relation to the kind of the human condition. Again, estimates as high as 700 billion. Recently, there was thought that may be off by 50%, meaning 50% low. So, somewhere in the neighborhood of potentially $1 trillion a year. Healthcare costs, crime, lost productivity, et cetera. And in fact, one of the more important things, one of the interesting things, probably relevant to this audience, are some development of employer-based calculators. So if you're not familiar, you can look up an employer-based calculator, so any employer can figure out how much this issue is costing them within their own workforce. The death rates have skyrocketed, and I'm going to show some graphs about that. And then the important update that I mentioned at the beginning was that the fact that the CDC thinks at least 42,000 people died in 2016 from overdoses involving opioid pain relievers, and that includes all opioids. Some public health officials have looked at, and epidemiologists have looked at that number and gone back to mortality data, including some review by coroners and the complexity around how they determine who died from an opioid use disorder or opioid overdose. And found that in some states that number may actually be underrepresented by as much as 100%. Ohio, where I work, is potentially one of those states. So, yet again, these numbers are concerning, but it's potential that they are on the low side of accurate is pervasive. We use too many opioids in the U.S. Everybody knows that we spend a whole lot of money and that our health outcomes are not equivalent to the spend or representative of. And so one of the factors that a lot of people have a question about is why is this so bad in the U.S.? Now, to be clear, it's also very bad in other countries, including the UK, Canada, as you can see on here. But if you read, articles about British Columbia and the state of opioid use disorder there, it is, it's just as bad as the worst areas of America. But we still use more opioids in general, and there's a long list of reasons that I'm sure many people are familiar with, including pain as a vital sign, patient satisfaction drivers, the pharmaceutical marketing, the general unwillingness of the U.S. populace to tolerate any sort of pain or discomfort. So there's a lot of reasons that this is the case. But nevertheless, these are the numbers. We also know that the risk of continued opioid use increases substantially at 4 to 5 days. And this was a study from 2015 or 16, and there was a more recent one just a few weeks ago that showed, replicated this issue that, the longer the prescription, the more likely the risk of continued use is the case. And we know that to be a problem because I'm sure people are aware, very common at least 5 to 10 years ago to go have even a mild to moderate procedure such as a small bone fracture fixation and get 60 to 120. And in fact, in our own treatment organization where I work at BrightView, the common story is actually primarily with C-sections, where women were leaving after a C-section, which I'm very sure is a very painful condition, but leaving with between 60 and 120 doses of prescription opioids. And obviously we can see by this graph what the chances of that turning into a problem are. We've seen a substantial uptick in heroin and other synthetic opioids, and I'll talk a little bit more about that in a second. But the reality is the whole class of medications and illicit drugs is actually quite an issue. The 116 data, I've actually used this slide and modified it on purpose. I promise you it's not just laziness, but modified it to show the changes that have gone on since 2015. So the bottom left of the slide is something I want to review, but if you'll notice that there's an arrow over the 78 because that was a 2015 number, and it was 91, and now 116 people die every day. So on an average day in the U.S., this was in 2015, and I think that some of the prescription opioid numbers may be going down, but in 2015 we were dispensing more than 650,000 opioid prescriptions a day, which is really an issue. 4,000 people, or almost 4,000 people a day, initiated non-medical use of prescription opioids. Again, meaning they admitted to it, which we know is not the whole number. And then 600 people admitted to initiating heroin use per day. New people on those second and third points on the average in the day in the U.S. And so when we see these numbers continue to go up from mortality and the cost of the issue, it shouldn't really be surprising given these numbers that are here on the left, and speaks to some of the epidemiology that's been represented as to when we might actually return to a baseline opioid mortality, being potentially somewhere in the neighborhood of 10 to 20 years. We have seen a substantial shift to heroin and fentanyl, so although I absolutely agree we should have placed increased restrictions on the prescribing of opioids through clinical scenarios, I think that we had to do what we had to do there, but probably were remiss in not simultaneously increasing the number of treatment, the available treatment capacity, because we know from animal studies that animals will not stop using opioids. So to clarify that point a bit, studies have been done on primates that demonstrate they will stop using things like alcohol or cocaine if the negative stimulus, i.e. Electric fence or sharp objects or whatever else, if the negative stimulus is high enough, they'll just quit using alcohol and cocaine, etc. That is not true for opioids, and in fact, they will nearly dismember themselves in an attempt to get to the opioids because the drive is so strong, which can explain why people can act very bizarrely and do terrible things to themselves and their families, etc., when in the throes of opioid addiction. It also meant that as we move towards reduction in prescribing of opioids, that we basically should have known that we were going to have an increase in the scenario of illicit heroin and then now fentanyl use. For the drug dealers, this is really an equation of economy as to why we're seeing more fentanyl. So the drug dealers figured out that we had a large populace that were dependent and or addicted to opioids, and they thought, of course, they can bring illicit heroin into the U.S. or manufacture it here or whatever. Well, when they figured out that fentanyl was a much better economic decision, so far as transport, as well as just the simplicity of making it, etc. Of course, the transition to synthetic opioids and fentanyl with its much higher potency, therefore more easily transportable and then cuttable, of course, it wasn't a far stretch for them to make that economic decision. And unfortunately, the consequence of that, of course, has been mortality. In the region that I work, Ohio, Kentucky, and then Indiana, West Virginia, I actually live right in the crux of all of those. We have a disaster. It's, this is like, I commonly say this is like Ebola actually went terribly bad. And so we're managing epidemic worse than really anything in U.S. history for sure, and potentially in human history when looking at this situation globally. And I do want to mention a very important point at the bottom of this slide. Although we have an opioid crisis, we also have a mounting alcohol and stimulant problem. So we are sometimes forgetting about the issues of a completely legal drug of alcohol, and then other legal or illegal drugs in the stimulant class. And so I think that we may be missing a little bit of the kind of the tidal wave of those other issues, including alcohol and benzodiazepine dependence, because of the mortality of the opioid crisis that we're seeing, which is clearly represented on this slide. I do want to make one point. So originally trained as an emergency trauma physician, I spent many hours in an amazing place at the University of Cincinnati to see someone come in from a car wreck, and just the resources and the intensity that would descend upon that patient to make sure that they survived their accident was quite amazing. Now, as a side note, a lot of those accidents were, of course, due to drugs and alcohol. So as a related tangent, but over time, with the improvement of both trauma intense services, as I've described, as well as automobiles improvement, we can see in the top right corner that as early as 2007, the rate of drug poisoning surpassed the motor vehicle accidents in death. And of course, you can see at the end of this, I mean, I don't have an updated one because it doesn't exist. As far as I can find, the suicide increase has been recent as well. In Ohio, these are the 6 counties people talk about quite frequently: the Warren, Butler, Summit, Hamilton, Cuyahoga, and Montgomery. The relative cities that are more recognizable are in the last 3, Cincinnati, Cleveland, and Dayton. And so we clearly have a terrible issue here in the Heartland in Ohio. I'm going to shift gears for a second and talk about the disease. So obviously, not knowing the audience personally, because we're all on a webinar, I'm not sure exactly who, whatever background everyone's coming from, but in medicine, we talk about definitions very importantly because that's how we converse about the disease state of a patient. Meaning, when I call a cardiologist and say I don't just call them and tell them their heart is bad. I call them and have a very specific definitional description, to the best of my knowledge, about what is wrong with their heart so that they can intervene upon it most accurately. It's an important part of medicine. And so I bring this up because the definition of disease and the definition of disease of addiction are almost exactly alike. Yet I spend very many times throughout every week, I lecture quite frequently on the issue that is that this is a disease, and I have to, quote, convince people because they want to think it's a moral failing, et cetera, all else. And I'll get to that more in just a minute. But to be clear, it fits the definition and it can be fatal without treatment. And with opioid use disorder, often is. The disease of addiction is actually quite terribly fascinating. It preys upon some of the most basic functionality in the brain and survival techniques. And again, going back to the animal primate study that I was mentioning, it makes sense when you talk about why people do such crazy things to get to opioids, especially, and not to mention other, drugs and alcohol. It's a very complex disease of neurochemistry involving, again, the pathways of our brain that really cause a lot of the very basic functions of seeking shelter, taking care of our children, seeking food, sex, etc. It really does alter and prey upon those core pathways of human function. And I tell people, frequently that I use the phrase that I've already told you all, which is it's terrifyingly complex and fascinating, because we really have a long way to go insofar as it's learning. But on the same note, people assume that we don't really have good therapies, we don't know what we're doing, we don't have good medications, and that could not be farther from the truth. When I have a conversation with a cardiologist about the bottom left imaging, the decreased heart metabolism in the heart disease patient, I call them and I say, hey, Bob Smith has this diseased heart on this PET scan or other imaging. We don't really go, there's other questions, but we at that point have, basically agree this heart is diseased and we need to do what we can to treat it. Yet, although we have the same images in the top left and then on the right, provided by NIDA, and I say, hey, we have, evidence of this disease, I still spend a ton of time, convincing people. What's interesting about that, like I said, is that it seems that despite all of this evidence, and Dr. Volkoff from NIDA and her colleagues had spent a ton of time on this, sometimes when I show these things, it's like people think I drew them in some sort of crayon, like I'm just making this up. And so I just wanted to make sure everybody understands we are in no way, shape, or form still trying to prove that we understand that this is a physiologic issue. We know that it is, but because of people's stigma and preconceived notions, and potentially even their personal heartache in dealing with a family member or other person who's had the issue, it's a struggle for people to come to the conclusion that we're dealing with a disease. It is also comparative to other diseases. So on the bottom right here of this slide, you'll see that the comparison of relapse rates between drug addiction and other chronic illnesses is exactly the same. So type 1 diabetes, hypertension, and asthma. I gave a lecture to many emergency physicians just the other day who said, well, why would I, start treatment in the emergency department? Won't they just come back? And I said, guys, if we had that perspective, we would never prescribe insulin, antihypertensive, or breathing treatments for asthmatics, because that's what we do all day in the emergency department, is take care of people who, for a myriad of reasons, are not managing their chronic disease, or it's just severe and it's the only way that they can manage it. And so realizing that this is a chronic collapsing disease and not getting mad at patients about their struggles to get to recovery is a really critical issue. To that effect, of course, never did, nor would I, nor have I really seen many physicians willing to yell at the type 1 diabetic, hypertensive, or asthmatic who shows up for repeated chronic treatment. This slide is probably one of the most important, and I'm going to make a case for something that I think hopefully will help you all come to understand, why I see the things the way that I do in regards to addiction. One of the most common factors or issues that people bring up is that this is just a choice. They just need to stop. They need to choose to stop using drugs or alcohol. Let's just make this let's make this a moral failing, and it's their choice. And so we know that actually the development of addiction is very complicated, but dependent upon many of the factors, primarily the ones you see here on this slide, which are biology, environment, and exposure. So up until maybe a few months ago, and I'm not sure actually what they're really doing in China with the gene editing, but up to a few months ago, the human race, no one has ever chosen their genetics. Not really. Very few people had any role or choice in their environment. So when you grew up, you were brought up in whatever household kind of you landed in by fate or other factors. And if your parents, or if you had split parents and they were abusive or whatever else happened, and you had adverse childhood events, which is a very common predisposing factor to addiction, I doubt anyone chose to be chained to their boiler like those poor kids in California. So no one chose their genes, no one chose the environment they grew up in. And then exposure is the last factor that we know to be the case. And exposure is rarely a choice. So it's not that someone didn't choose to smoke that joint when they were 14, but they were probably pressured, and maybe they had bad things happen to them as they were trying to escape their abusive parents, et cetera, all else. In addition to that, primarily for opioid use disorder, we know that a vast majority of the exposure is actually primarily medical first. And so I doubt, again, that any young lady who had a C-section chose to be in that much pain. Any person who fell off a roof and broke their back chose to do that. And so exposure has limited choice related to it. At the end of the day, hopefully I've been able to convince you all that choice has very little to do with this. It would be a much easier disease to treat if it did. Development of the brain is actually quite interesting. So 2 points on this slide, one of which is we know that teenagers don't really behave rationally. Well, there's actually a scientific reason for that. I have one teenager, one younger child, and I know for sure he does not behave rationally. He probably doesn't appreciate me sharing that on this recorded webinar. But I'll tell you the story that made me realize this recently. Before it got cold, my wife and kids and I were in the garden with him and his younger sister, and he was throwing the spade shovel at her feet. And before I could think about my adolescent educational training, I yelled at him and said, "Why are you throwing that at your sister's feet?" Of course, the answer to that is he had no idea why he was doing such a thing. And his prefrontal cortex is not developed. So he wasn't thinking about the consequences of what would happen if he had struck her foot with the spade shovel. So we know kids don't really make all the best decisions. That's why we are parents, and hopefully most of us are good ones. But this is a really key and critical time, and I'll talk a little bit more about prevention in a second. So what are we going to do about this terrible crisis we're in? We'll go back to that. Those of you who aren't familiar, this is Pinky and the Brain, of course. Well, this is complicated. If I haven't convinced you of that, we should probably stop now and not have the rest of the webinar. But hopefully you're convinced this is complicated. And we're going to have to work on this in the 5 following categories: prevention, treatment, law enforcement, appropriate prescribing, and harm reduction. I'm going to talk a little bit more about each one of those, with the exception of law enforcement. I'm not a law enforcement official. I work very closely with many of them and respect them to the nth degree. And in fact, law enforcement, including county jails, et cetera, are actually quite a bit ahead of medicine in the role in resolving the opioid crisis, doing things like jail-based detoxification, et cetera. And so it's interesting to me that I actually spend more time convincing my medical colleagues of what we should be doing, which has much more to do in categories 1, 2, 4, and 5. I'm going to talk for just a second about prevention because this is very important. There's been a whole lot of confusion across the country over years about what prevention is and what it means. And then I'm not going to get this. That's actually a whole lecture, and there are entities that specialize in prevention. I'm just going to mention some key points. First and foremost, if we're ever going to stop the tide of this situation, we have to stop the entrance into the opioid crisis, and that's going to have to do with prevention. And again, I have 2 small children, and I do worry about them despite what I specialize in. The Institute of Medicine described 3 categories of prevention and intervention: universal, selective, and indicated. You'll notice that I will not be talking about just say no or this is your brain on drugs, because actually that stuff didn't work, and neither did DARE, and we have evidence that it didn't. But these forms of prevention are scientifically based, evidence proven, and again, to go back to the Surgeon General's report, were well reviewed, and they lay out the ones that were effective. it gives you the definitions here. I'm not going to read for everyone what universal, selective, and indicated interventions are. Surgeon General's report reviewed 600 prevention programs, found 42 evidence-based strategies proven to reduce the number of people who start using drugs or alcohol, or who progress to harmful use, so both primary and secondary. What's most important about these school, family, and internet-based programs is that they are ongoing, supportive, and generally help people to learn how to cope with challenges. So if I need to make another important point for everyone on the webinar, it's that is the key with prevention. Intervening early, often, and consistently is how we do this. And again, scare tactics, people showing up and telling them that they've arrested this many people or this many people are dead, it actually doesn't work with kids or adolescents. It may have something to do, in fact, probably has something to do with the fact that they don't have a whole lot of frontal control of their thought processes. And so scare tactics are not effective, unfortunately. Fortunately or unfortunately, they're not effective. And so what is effective is a consistent, standardized message using evidence-based strategies that have been proven to work. When I'm talking to my medical colleagues, we talk about the trajectory and arresting the descent in categories of patients. The reason that we need to talk about that is because we need to start grouping people and thinking about how we're going to treat individuals, kind of in their own framework, because, obviously people are very complicated. No one's really the same, but we can't come up with 21 million different answers for that many people. So 3 general categories of patients to think are never exposed, minimally exposed with no dependence. So as an example, a relative of mine had a very small wrist procedure, limited exposure prior to that time, maybe 1 or 2 other opioids for serious surgeries, got 1 or 2 doses of opioids post-surgery, otherwise rest ice, elevate, ibuprofen, Tylenol, and pain management, not pain obliteration. And that person, of course, subsequent to that procedure had no real issues with opioids. So if the person never needs opioids, let's always make that not the last resort, but kind of a understanding of the risks and benefits when exposing patients to opioids. And if they are exposed, let's make sure we limit that exposure. And those people that have been exposed and dependent, we need to do a better job of identifying, screening, and transitioning them to other forms of pain management, up to and including partial mu agonists, which I'm going to talk about in a second. If you don't recognize the word buprenorphine, the common term is Suboxone, of course, but that's the chemical buprenorphine. Buprenorphine can actually have a role in transitioning people. Partial mu agonists like buprenorphine are very safe. It's safer than full mu agonists like oxycodone, hydrocodone, etc. And so early identification, screening, and management of those who are exposed and dependent is very important. We have a huge population of the U.S. Some people will need to be on chronic opioids, and I'm not quite yet to why long-term maintenance treatment for opioid use disorder is important, but some people will be. And we need to recognize that, and we need to make sure that we're aware and concerned and cautious with those patients who have chronic severe pain, and we don't cast them out, the baby out with the bathwater, because that is a real concern of many patients, many people across the country, and it should be. We have an immense amount of legislative and regulatory oversight going into this issue, and people are abandoning patients in pain, and that is a real problem. For the third category, opioid use disorder, those who are defined to have a problem, addiction to opioids, long-term medication-assisted treatment with supportive psychological and social interventions is the treatment. And I'll define that better in the next few slides. To review, the chronic relapsing biopsychosocial disease definition comes from every entity you see on this slide. It is not Shawn Ryan's version of the definition. It is not even just one of these entities, but ASAM, the NIH, SAMHSA, the APA Surgeon General, and the Veterans Affairs Department all agree. This is a chronic relapsing biopsychosocial disease, and the treatment must address the 3 components, which are the biological, psychological, and social. To that effect, we have to understand this is a neurochemical issue primarily. It happens to have psychological and social consequences or predisposing factors, but this is primarily best managed by medical interventions. That includes, comprehensive assessment and intake as soon as possible when discovered, outpatient withdrawal management, not detox, and we'll talk about that in a minute, medical stabilization services, meaning obviously people who are severely ill from alcohol or drugs don't tend to show up in wonderful health, and then, of course, medical care coordination and monitoring. Psychologically, it's actually, again, quite intricate with these patients. They really do need appropriate assessments of their psychological condition and placement and level of care by ASAM placement criteria, and then the appropriate therapeutic interventions, whatever that might be, individual, group, family, trauma-based care, whatever it is that is appropriate. And then I often tell people I'm very blessed to work in a multidisciplinary environment where I have actually psychologists, therapists, case managers, etc. Because I'll tell you that despite my extensive training in the disease of addiction, I really can't do a whole lot personally about a lot of the things you see under the case management situation, which can be just as important as what we do on the medical side. So again, one point to take home: treatment equals medical, psychological, and social interventions. It does not include one of them. It does not include just medical or just social. So those quote treatment programs that say we just talk to them about their disease, they don't work. To be very direct, those people that say I'm going to solve all these problems with just medications, again, not accurate. People are very complicated and need this multidisciplinary cares to have the best chance of sobriety and recovery. We're going to spend some time now on medication-assisted treatment. This is a very, very hot topic and controversial for some people. And I want to start with a little bit of the history so that we get a little bit more frame of reference. I also think it's important for everybody to understand from basically America's frame of reference or the human frame of reference. We've been misusing opioids for thousands of years, and we've had multiple opioid epidemics or consequences related to that in large-scale populations, including in this country starting in the late 1800s and early 1900s. Because of that, we've been seriously attempting to find medications to treat this since the 1920s, including over 150 compounds that have been tried, including, as you can see, heroin to get people off of morphine, which was an interesting mistake, and then many, many, many others. In 1962, Dr. Dole, a specialist at Rockefeller University, and his colleague, Dr. Marie Nyswander, had been working on these issues. And in 1956, Dr. Nyswander concerningly said, and the reason I say concerningly is because we still seem to not understand this, many patients would have to be maintained on opioids. At that time, they were primarily referring to methadone, for extended periods of time to function because significant number of people attempted abstinence without medication relapse, in spite of detox, hospitalizations, and psychotherapy. What is astounding to me is that that she could have said that yesterday and we'd still be having an argument, but she didn't. She said it in 1956, and here we are. Then, of course, Narcotic Treatment Act of 1974 effectively limited methadone to OTP settings, which I don't disagree with because it's an effective but it can be a fairly risky medication when misused, and we need to control it carefully. And then you could see here that naltrexone and buprenorphine both synthesized and made in quite a many years ago, despite the fact that we think these are new therapies. And then buprenorphine was approved for opioid use disorder treatment in France in 1996 and 2002 in the U.S. The evidence is overwhelming, folks. I hear people that say I don't, quote, believe in medication-assisted treatment, and my response to that is I don't know what you mean by that. This is not theology or philosophy. This is science, and we as scientists react to it by studying the evidence and saying, oh, yes, I understand what this evidence represents, not I believe it or don't believe it. So for methadone, in 2013, and these were not the first studies by any stretch, but the more recent and more profound, we have a meta-analysis and systematic review of individual studies of MMT as methadone maintenance therapy from 1995-2012. 9 studies, high level of evidence for positive impact, treatment retention, and illicit opioid use reduction. Buprenorphine, again, same article, 2013. 16 studies, high level of evidence for positive impact of buprenorphine maintenance therapy on treatment retention and illicit opioid use. Not subtle statements in medical evidence. Physicians and other scientists that write such articles don't tend to make profound statements based on very minor details. Subsequent to that, of course, we had Dr. D'Onofrio at Yale, ED initiation of buprenorphine showing a substantial increase in increased attendance, in outpatient treatment at 30 days when patients were started on buprenorphine in the ED. And unfortunately, we're just now starting to have any sort of ramp up in discussion in the emergency medicine field about possibly doing that. Dunlap et al. In JAMA 2016. Again, these are journals of high impact in medicine, not things. These are not, again, Norwegian journals of basket weaving. These are the journals that medicine turns to for the best evidence. Clinical guideline synopsis, clinical management of opioid use disorder. MAT, superior to withdrawal alone in multiple studies. Not a subtle statement. And then in 2017, Sordo et al. In the British Medical Journal came out with an analysis that allowed me to say something quite direct. And I'll tell you all, after I read this study, and I was already convinced, if you couldn't tell, after I read this study and I said, all right, to be clear, this says 140,000 people between the methadone arm and the buprenorphine arm, and they said retention in MMT and BDMT is associated with substantial reductions in risk for alcohols and overdose mortality. And I said to myself, given this evidence, I have to say the following. Not offering medication-assisted treatment of one of those two types to patients with opioid use disorder is malpractice. And I don't care what environment you're in. If you're in an abstinence-based treatment program, you need to be having this discussion. Why are we doing that? Why are we putting these people at risk for this level of mortality with opioid use disorder? And so I am challenging my colleagues to start really understanding how strongly we need to address the evidence that I'm showing you right now. As if that wasn't enough, the Surgeon General's report that I've already alluded to, of course, says abundant scientific data shows that long-term use of maintenance medication successfully reduces use, risk of relapse, overdose, associated criminal behavior, transmission of infectious disease, as well as helps patients return to a healthy, functional life. Yet again, I couldn't write a stronger statement. And unfortunately, use of medications to treat addiction has been controversial because of this misunderstanding that it's one drug for another, just like insulin is for people who need insulin. This belief has reinforced scientifically unsound abstinence-based philosophies in many treatment centers, severely limited the use of these medications. I will tell you that in the medical legal world, when you have this level of evidence, these level of guidelines, it's nearly impossible to medically legally defend someone who chooses to step outside of them, and I would not want to be on that side of the fence. And then to finalize, of course, the VA practice guidelines say the same thing. Strong recommendation for people with opioid use disorder. So, basically, buprenorphine, naloxone, or methadone, and OTP. And then I'm going to talk a little bit more about Vivitrol in just a second. Detox doesn't work. Never did, never will. We do not have any evidence whatsoever that just, quote, detoxing is helping anyone in any way, shape, or form. Of course, we need to kind of move on from the term detox and talk about withdrawal management, which is more medically accurate. But in this slide, we're really referring to the important information that buprenorphine versus placebo, meaning, so if you look on your left, detoxification is a green line, and that's all they did. They just gave them some medications to make sure they were, quote, off of everything by the time they left. And none of them actually remained in treatment past 60 days, and 4 of them died. As opposed to that, maintenance on buprenorphine on the red dots had a nearly 75% retention at 1 year. None of them died. And this was an article from Lancet of 2003. Since we can't seem to have translated that into practice, it was revisited by JAMA in 2014. Buprenorphine treatment for hospitalized opioid-dependent patients. And on the left, you'll see an infographic representing the data from that study. You see on the left of the gray and blue, you'll see an infographic representing the data from that study. So rates of treatment continuation after discharge from hospital. One of the most important things in medicine is a treatment plan that's a continuum and not a single intervention, of course. You don't want to do a cardiac catheterization on someone and intervene upon that coronary disease and then tell them good luck. They need to be on medications ongoing, of course. In this case and situation, it is the same. On the left, you'll see that MAT initiation and maintenance resulted in 72% of patients actually showing up for outpatient treatment. But if you just detoxed them and told them to go to treatment, only 12% showed up. And more importantly, at 6 months, there was a linkage to treatment and continuation of MAT. In that arm, 38% of people had absolute cessation of illicit opioid use, while only 9% of people in the detox arm did. So, point here, detox doesn't work. Don't let anybody convince you that it does. Let's talk about antagonists for a second, because this is a hot topic. So, especially in the justice system, Vivitrol is a favored medication for opioid use disorder, and there's reasons for that. actually no possibility of diversion, which is completely understood, as well as the more inappropriate or very inappropriate concept that this is not a drug for a drug. It actually is a drug for a drug, to be clear. So I'm giving somebody a drug because they have a drug problem. It happens to not activate but block that receptor, but that's not really a good scientific explanation. So to be crass, it is still a drug for a drug. Now, historically, the evidence for Vivitrol actually wasn't very good. And so up until the fall of this year, and so in late 2017, I spoke to the evidence on this issue and said, hey, it's just not strong. The original approval evidence wasn't strong from the FDA, and neither was any of the follow-along evidence. That being said, I actually feel much more comfortable about Vivitrol's efficacy after the XBOT trial that was done recently, which says that at 6 months, there was equivalent evidence between naltrexone and buprenorphine. There are a few issues with this, of course. So to be honest, there was subsequent discussions of this thing. Hey, now Suboxone's equivalent to Vivitrol, or excuse me, vice versa. And unfortunately, for those of us who spend most of our lives on this issue, that's not actually the case. Vivitrol is a good medication for the right patient, and we use it frequently where I work in the right situation. But in the XBOT trial, they actually had 1 in 3 patients that couldn't get onto Vivitrol. So the time of transition from illicit drugs to the right medication, they had a significant failure rate during that transition. In addition to that, this is, again, about 600 patients for 6 months. I would challenge you to attempt to equivalently represent that data to the bottom of this slide where they talked about years of data and 140,000 people. So despite my newly found support of Vivitrol as a medication, and I'm excited about that, we do not yet have equivalent evidence, nor probably will we ever have that many people on it, at least not for quite some time. And so when strictly abiding by the evidence, just being aware that they're both the antagonists and agonists are both very good medications for the right patient, but that needs to be a medically driven decision in consultation with the patient, just like any other complex and challenging situation. I will say one final caveat to everyone on the conference here. If we had a medication that was not a mu agonist that worked as well as buprenorphine and methadone, I would use it. There's confusion. People get kind of bent on to belief in one thing or another. I don't personally actually have any of that. I think that scientists, we have to approach this as objectively as possible, and I'm trying to save people's lives and keep them safe and getting the recovery. And for that effect, I'd use anything that would and actually would definitely prefer to use a non-controlled substance if I knew the efficacy was there. Because the last thing I enjoy doing every day is the amount of paperwork required to prescribe a controlled substance. So just to be clear, I hope it proves long-term to be as effective and would be excited to have any non-controlled substance that works as well as buprenorphine and methadone. Evidence for comprehensive addiction treatment. This is just a little bit of a review of why I choose to work where I work at BrightView with a comprehensive addiction treatment practice. Including the medical, psychological, and social components. So every recommendation for medication-assisted treatment includes that. So that's pretty sound. ACM, NIDA, SAMHSA, Surgeon General, the VA guidelines, etc. So we can start there. The evidence is also very important to review. So Dr. Weiss in 2014 did a review and said that not all patients will require counseling. And I agree with that statement. There was a subset analysis of that study that showed that actually anyone who'd ever used heroin did better. Now, why is that the case? Probably has something to do with either the trauma that led them to using heroin or the trauma of using heroin. But regardless, very few people show up in our treatment sites after using heroin and don't need somebody to talk to about the issues that they have developed or that led them to that use. Lynch et al. Also talked about the cost effectiveness. So for those of you who didn't remember the first slide, I did my MBA during residency at the Linder School of Business here in Cincinnati. And I addressed a lot of this from a mathematical and financial standpoint, which I'm going to get to a little bit more in just a second. But the impact financially of addiction counseling plus addiction treatment, MAT plus counseling, was significantly lower healthcare costs than those patients with little or no addiction treatment. And then finally, the Journal of Addiction Medicine in 2016, Dugash et al. Did a systematic review of psychosocial interventions and basically says, we're not entirely clear which one is the best for each patient, but we know that in combination with medication, it's more effective. So I think we still have some more work to do to understand which types of therapy are most effective in each patient. I will say, no question, opioid agonist therapy alone reduces mortality, and that was proven in a study as well. The VA did a study that said you can either wait for counseling, and we'll start you on medication-assisted treatment at that time, or you can start MAT, and then as soon as a counselor is available, we will get you to them. And the arm that started on medication-assisted treatment, immediately, there was a 66% mortality reduction. So despite the fact that I am very supportive of the complete psychosocial intervention model, biopsychosocial intervention model, we do need to realize the mortality reduction of agonist therapy alone. Treatment need, we are not even close to where we need. You can see on the left the number of physicians, 800,000. This does not include advanced practitioners, which I'm happy to take and now prescribe buprenorphine. But the U.S. physicians is 800,000, 33,000 of which it's more like 35 or 36 at this point because we've been doing work. But only a third of those prescribe, and very few of those actually prescribe on a regular basis. So we're not even close to the amount of need that is present for medication-assisted treatment for opioid use disorder. Treatment impact, one of my favorite slides. For every dollar we spend on treatment, cost of crime and lost productivity reduced by as much as $7.46, with a total cost reduction as much as $18.54. There is not another dollar we can spend in healthcare that is as impactful as this one right here. There's none. Not aspirin, not insulin, nothing. And so we need to recognize that the financial burden alone should convince us that this is the right pathway, that treatment is the way out of this mess. Patients with substance use disorder often use a disproportionate amount of healthcare. That's also not news to anyone who works in healthcare, that we see patients with mental health and addiction more often than anything. Specifically, Alan White in 2010, and if you haven't looked up any of the analytics from Alan White, please do. Very bright gentleman from Massachusetts. They did an analysis in, again, 2010 that showed that mean annual direct healthcare costs for opioid abusers were 8 times that of non-abusers. And just as a reminder, medication-assisted treatment plus counseling significantly lowers those total healthcare costs. One little caveat on the end of that, there have been other studies, so that study was pretty good and showed 6% reduction. But other studies, including one out of Michigan, demonstrated 90% reduction of healthcare costs when focusing on patients who have mental health and addiction with the appropriate resources. Looks like we're going to leave some time for questions, which is exactly how I like to end up. And in summary, this is a disease, and prevention is very important. So I'll tell you personally, I will be doing everything I can to support my kids and my kids' school in doing evidence-based prevention, not scare tactics, in order to kind of alleviate any, as many as we can, kids arriving in this terrible disease state years to come from now. And I will say that we have a significant neonatal abstinence issue in the country dealing with opioid addicted mothers who are delivering children, and we don't really know what that is going to be years from now, how that's going to develop, but we better get good at prevention. Adolescent drug exposure can have important effects. Any mind-altering substance in adolescence can have an important trajectory impact on people using drugs later in life. Medication-assisted treatment works, and it saves lives. Identify and refer patients rapidly. They need to see somebody tomorrow if possible. And that person they see needs to have access to medication-assisted treatment. Abstinence from opioids and mortality reduction is not to be questioned in relation to medication-assisted treatment. And of course, when multidisciplinary practices are available, like I've described, that is definitely best practice. We have a long way to go to turn this tide on the opioid epidemic. I've mentioned I've worked with many epidemiologists on how complicated this is and when we might have some more positive news. I hope that this year in 2018 we're going to see some evidence of the tide turning, but returning to a baseline opioid overdose mortality is going to take us several years. And I also, as a scientist, am excited about the new evidence and the new medications coming out. So that years ago, when I was working only in the emergency department and I would repeatedly see the same alcoholic or drug abuser, and I would say, hey, I'm sorry, I have no idea what to do for you. I'm glad to say those days are leaving. And as long as we can educate more people, we'll get there. I think that that's all that I have to say for the time being, and I would invite questions from those of you who are on the conference.
Dr. Ryan, thank you very much for doing this presentation on such a hot topic for all of us. We do have a couple of questions. Number
Excellent.
one, what are your thoughts regarding prescribers who primarily prescribed Subutex over Suboxone for opioid addiction treatment?
Sure, it's a great question. Actually, way more complicated than people think sometimes. So the medical indication for Subutex only is actually pregnant patients. Very, very few patients are actually, quote, allergic to the naloxone component. So great question. It's somewhere in the order of 1 in 10,000. I've actually never seen one, although I have a few patients on Subutex because of recorded instances of severe allergy, meaning ending up in the emergency department. They came to us with evidence of that and proof of the medical documentation. Of course, we were not necessarily willing to induce anaphylactic shock given that evidence, but it's very, very uncommon. That being said, on the pregnant patients, there's actually quite a few of my colleagues who are very comfortable prescribing the combination product to pregnant patients given the concerns of possible abuse of Subutex. In addition to that, it is a cost issue. So one of the things that gets lost sometimes is the fact that Subutex is the cheapest version. And so if the patients have no insurance and are self-pay, or they've lost their insurance, which of course happens because keeping insurance is actually a little complicated, then sometimes physicians will prescribe primarily the mono product for cost basis. And I'll tell you all directly, if I had a patient came to me and said I can't afford a combo product, and I did all the appropriate diversion management that we do at our practice, and I believe them, I'm not going to let them die because they can't afford the combination product. But that again, I'm describing very limited instances, and so I'm not saying it's not possible, but it would be a question to me. It would raise a flag in my mind if I saw a practice primarily prescribing Subutex for the reasons I just elaborated on.
Okay, well, thank you for that. Let me tell you the next question, if you don't mind. What are your thoughts regarding buprenorphine patients receiving gabapentin, benzodiazepines, sedatives, and/or stimulants? We are seeing these combinations being prescribed by certain prescribers and find it to be rather concerning.
Understood. So as with any combination of medications that could be psychoactive, it's a risk-benefit equation that the provider must understand. And so are benzodiazepines and buprenorphine dangerous together? There was actually a little bit of an urban legend issue with this. They're not nearly as dangerous together as people were led to believe. And in fact, some practices have an absolute contraindication of those two things being prescribed together. And the good news is that the FDA came out and said, hey guys, we think this is actually probably overplayed, and they're not nearly as dangerous as, say, heroin and Xanax together. So to be honest, if I'm seeing a patient who comes in who I'm going to have to transition from a Xanax dependence and a heroin use, and I'm going to put them on buprenorphine and a long-acting benzo like Klonopin or Valium while attempting to manage them off of it, you will see. I mean, admittedly, I do prescribe that combination in very limited circumstances. Now, could it be that a practice might have, if they're the only addiction specialists in 200 miles, they end up with all those very complicated patients? It's possible. And one of the very challenging things to understand if you're on the outside looking in, if you're a pharmacist or a pharmacy regulator or other regulator, and you're saying, well, why would they be doing this? There again are limited circumstances where I can say that it would be possible that they could end up with a preponderance of those types of patients. That being said, I'm not really sure that that's that common. And so it is important that the providers are given guidance that these things should be limited circumstances and include very kind of conscientious documentation of why they might be doing such a thing. On the issue of gabapentin, we have a particular kind of conundrum because we have people who are trying to get off of chronic opioids, whether it be illicit or prescribed, and gabapentin is actually a reasonably effective medication for neuropathic pain. But can it be abused? Of course. People also smoke banana peels and inject scorpion venom in themselves to get high. So the limits of what humans are willing to do to themselves to get high is actually far beyond the use of gabapentin. But I would go back to my original summary, which is providers doing this, it should be minority, not majority, unless very, very weird circumstances arise. And they should be clearly documenting why they're doing that. And then the final tail end of that is I will say that a lot of physicians in the field feel like there's some harm reduction situation at hand. So if a patient comes in on Xanax, heroin, and cocaine, then I can transition them to buprenorphine and gabapentin, keep them alive while I'm managing their pain and trying to transition them off of more and more things. Polypharmacy reduction is my strategy and our practice's strategy. Then I'm going to do those things. And so there are cases in which we will see these prescriptions which looks concerning, but are definitely medically indicated.
Thank you. We have two more questions, and I'd like to be sensitive to people's schedules, so
Absolutely.
let's do the best we can. Is there evidence on the most effective length of therapy for people with substance use disorder? Also, any data yet on discontinuation of medication-assisted treatment and success of that over time for ongoing abstinence?
Absolutely. So because of time limitations, I'll try to be brief. We know that patients really do need to be maintained in their sobriety, whether that is on MAT or not, for at least the neighborhood of 2 years to see the brain changes that we like to see returning to more normal. And that happens again whether they're on MAT or not. 5 years is another marker people use for a substantial kind of, again, it's just like cancer, 5-year survival rate is another marker we use. Making us more confident, but people do still relapse after that time. And then I actually did review the evidence recently on buprenorphine and medication-assisted treatment tapers. And unfortunately, the evidence is not good. So it is successful less than 1 in 10% of the time. Excuse me, 1 in 10, so 10% of the time. And at this time, we're taking the approach that we will work towards that goal, understanding the risks and benefits of possible relapse.
Okay, next one, and this is the final question that we have. Do you have an opinion or do you have thoughts on the implantable medications as a type of medication-assisted treatment option?
What was that word? I'm sorry, I missed the...
The implantables.
Oh, the implantables. Yes, so I've done the probutene implant on a few patients, and in those patients, when they were appropriately and carefully selected, it was quite successful. And we have the new injectables with Sublocade and then the other version, hopefully FDA approved here in a little while. And I have significant hope in those because not only do they absolutely obliterate diversion in general, not that someone won't try to suck one out or something, but there's actually some evidence in relapse prevention with the probutene implant, which may be due to the constant dosage of medication as opposed to the whipsawing related to daily dosing. And so I've had success, we've had success, and I'm excited to see these new therapies have effect.
Wonderful. Well, thank you very much for this lecture. And I want to thank you on behalf of the International Healthcare Facility Diversion Association, IHFDA, as well as all of the participants. For those of you who are participants, I'd like to encourage you to watch for our next website, or our next webinar, I should say, in a series for 2018 and onward, if you will. I'd also like to encourage you to participate with us at our annual conference, which will be held in Dallas or Frisco, one of the suburbs, in October on the 22nd to the 24th of this year. We'd very much like to have all of you participate with us. These slides will be available to you within a few days on the member site, and we'd be happy to introduce any other questions, comments, concerns, or future topics that you might like to provide to us. So with that, I will say thank you, Dr. Ryan. We appreciate your interest and your topic for today, and thanks very much. This ends the webinar.
Thank you, folks.